Welcome back, everyone. Now we have a lecture on everyone's most dreaded topic, congenital heart disease. Med students everywhere are always not looking forward to questions with cyanosis and acyanosis and congenital heart disease. So, by the end of this lecture, you'll actually be looking forward to these kinds of questions. I know, scary thought, huh? So, the picture you see on the left is a normal heart diagram. And I know that all of you know what a normal heart looks like, but I'm putting it on here because many of these congenital heart conditions are going to switch the way this heart normally looks, and this is what leads to the problems. And once again, I'm Dr. Iyer. Nice to meet everyone, and let's get started. So let's start with a sample question. And the purpose of this sample question is to prime our brains for all the information that we're going to be learning today. So this is a question on cyanotic heart disease management. And like always, let's start with the question. Which of the following should be avoided in this patient's condition? So we're going to have a lecture on testing strategy, but the key word here is avoided. I'm sure you're all used to questions that say next best step in management, initial test, best test. Now we're switching it up. We're not picking the answer that fits best. We're picking the answer choice that doesn't fit at all. So when we're picking an answer in this question, we want to pick the one that's wrong, that should not work and should not be given in this patient. So first is prostaglandin E1, 100% high flow oxygen, Indomethacin and Nsaid, breastfeeding, and surgery. Alright, let's go to the question now. A male child is born to a 24-year-old mother at term and after 2 hours develops diffuse cyanosis. So it's a term baby and after 2 hours develops cyanosis. Oh my god, the baby's turning blue. Infant is breathing rapidly and has a decreased pulse oximetry of 84%. Vital signs are afebrile, heart rate of 155, respiratory rate of 60, and BP of 76/45 in both upper and lower extremities. So now, what are the normal vital signs for babies? Now, these are always very difficult to come across and difficult to interpret because they're so different from adult vitals. So I have some charts for you that'll help you. Neonatal vitals in the first month of life, and the heart rate should be between 120 and 160. So our patient's okay in terms of heart rate, maybe upper limit of normal. Respiratory rate is 30 to 50 a minute. This patient is 60, so the baby's having a lot of tachypnea, which makes sense because of the low pulse oximetry. And blood pressure between 60/30 and 75/45. So the blood pressure is a little high in this neonate. And this is in the upper and lower extremities. And the reason why we check the upper and lower extremities is to look for coarctation. And here are also some infant vitals. This doesn't apply to our infant because this is a newborn male child. But these are also some vitals that you need to know and have them memorized so you can interpret questions in the future that deal with infants. There's no family history of congenital heart disease. Auscultation of left upper sternal border shows a harsh, continuous, machinery-like murmur. So the left upper sternal border is showing a machinery-like murmur. And if you don't know what that is right now, that's okay, but we're going to go over it in our lecture later on. This is a patent ductus arteriosus murmur. It's in the left upper sternal border because it's connecting the aorta to the pulmonary artery, and this is going to be in the left upper sternal area. And it's harsh, continuous, machinery-like. This is the characteristics that it has. We'll talk about in the future why it has those characteristics. So the resident suspects a congenital heart disease, but cannot definitively diagnose the patient until he is stabilized. So let's talk about these answer choices now. We have a patient that has cyanosis and a PDA. Does PDA cause cyanosis? Very good, it does not. Usually it's a left to right murmur in the beginning, which does not cause cyanosis. So there's some underlying problem. And if there's an underlying problem that's causing cyanosis, having a shunt is actually important because that shunt will mix oxygenated blood with deoxygenated blood and allow the baby to survive. Now, if this is difficult right now, that's fine. We're going to go into a lot more detail later and come back to this question afterward when you understand all the material. But Prostaglandin E1 infusion, what this is going to do is keep the PDA open. We want to keep the PDA open so we can mix the left and right circulations to make sure that oxygen reaches the systemic vasculature and the tissues. So this is actually something you would give, and because we're looking for what you would avoid, this is the wrong answer. The patient has a pulse ox of 84. Do you want to avoid oxygen in a patient that has decreased pulse ox? Of course not. You want to give oxygen. So that's wrong as well. Indomethacin is an Nsaid, and what the purpose of this Nsaid is to close the patent ductus arteriosus in patients where it's not necessary. And we've talked before how vital this PDA might be to our cyanotic infant. We don't know for sure because we don't have any studies or x-rays or echoes, But for now, this PDA is keeping this patient alive most likely because of the cyanotic heart disease. So we don't want to give indomethacin, so we can keep this as an answer choice because it should be avoided. We do not want to close the PDA. There are very few indications to stop breastfeeding. Remember, breastfeeding is the #1 source of nutrition for the infant. So, breastfeeding is not an answer choice that we will avoid. It's most likely we're going to keep giving the infant to sustain him with nutrition. And last thing is surgery. Cyanotic heart disease is usually a problem that's congenitally wrong with the heart, and usually it's some kind of structural problem. The only definitive management that we really have for these kind of problems is surgery. So surgery should never really be avoided for congenital heart disease because it's our definitive treatment option. So the answer must be indomethacin. Alright, the answer is C.